Thank you. Thank you for your attention. I always hate to interrupt these conversations. We've gotten some incredible people to hear from. We have a busy month here at City Club, but I'm especially excited about today's program as it really embodies what we do here. As so many of you know, at City Club we convene, we collaborate, we don't necessarily compete, really to help encourage advancements that move Chicago forward. And in this case, it can really change the world. We bring together elected officials and public servants like Alderman Riley, Alderman Hopkins, Clerk Anna Valencia, and of course our state comptroller, Suzanne Mendoza. Thank you folks for being here. The former Deputy Governor Sal Flores is here. We've got philanthropic and nonprofit leaders. Julia Stash is here. Thank you. Laura Jane Hyde from Gilda's Club. Brenda Bowie from the Chicago Public Library Foundation. Thank you, Brenda. Tamara Newberger from the chair of Sister Cities, and of course, Adrian Tongate, who runs Sister Cities. We've got business leaders like Charlie Mills, Phil Clement from World Business Chicago, Adam Fine from Wyndham Capital, and of course, Laura Sage, who founded the Lynn Sage Foundation. And a special thanks to our friend Janae Myers for helping bring this all together and to our attention. And as so many of you know, in Chicago, we make no little plans. We're the birthplace of the skyscraper, reversed a river. There's so many things that invented the zipper. I don't know what else, but all the genres of music sent presidents to D.C. and now, of course, we have a pope in the Vatican. We do big things in Chicago, especially when we come together like this. And that's why I like to mention those folks from different sectors who are doing different things in their areas to better Chicago. We have some of the smartest people in the world here, especially in the medical field. Historically, I think we have one of the heaviest, concentrations of Nobel laureates from Chicago. That's pretty telling. That's because we have the best research institutions and the best hospitals in the world are here in Chicago. Kirsten's going to mention the brilliant folks that are in the medical field that are going to join us, some that you'll hear from today. But we've, especially those in medical, we had the first open heart surgery here was in Chicago. The first blood bank was here in Chicago. Dr. Watson discovered DNA in Chicago. These are big things. And how amazing will it be when a cure, or as we talked about, maybe not a cure, maybe a preventative measure is discovered to cure this monster of a disease that affects so many people. And so many of you are in this room, by the way, and they're friends. I know ComEd specifically has a table, and they are all survivors. Let's hear it for the survivors in the room. Those are the heroes who keep their families going and their lives going and keep doing all the great work that they're doing as they're fighting this horrible disease that these folks you'll hear from today are going to make some great advancements on. So I mentioned Northwestern University of Chicago and Rush, and those are just a few of those awesome institutions, and those are going to be represented here today. If we at City Club can even be the tiniest little catalyst in helping get this message out, helping raise funds, helping change policy, then we will have been successful as just bringing you all together. So thank you for being here today. Thank you for helping to understand why we're here and why this group of people came together. And thanks for just being open to collaborating. That's so important, collaborating for the right reasons. So I'm going to hand this over to Kirsten. She's a seasoned nonprofit and civic leader, a also a breast cancer survivor and a passionate advocate. She combines her experience with her deep professional expertise to drive innovation in research, education, and equitable care. Please welcome back to the City Club of Chicago, Executive Director of the Lynn Sage Breast Cancer Foundation, Kirsten Chanowski. And before Kirsten starts, please remember we'd like to come back to you for questions later. So keep your thinking caps on, and we'll come back to you after the panel. Thank you.
Dan, thank you so much to you and City Club for hosting us today. Don't forget your drink. Good afternoon, everyone. It is such an honor to be here with you today. Thank you. Not only do I get to be the leader of this amazing foundation, but I'm also someone who knows firsthand how critical this work is. Thank you for joining us for a conversation about collaboration, innovation, and the future of breast cancer research. Almost 10 years ago, at just 33, I became 1 in 8. 1 in 8 women to hear the words, "You have breast cancer." Like so many others, I was filled with fear and uncertainty, but I held on to something stronger. I held on to hope. Hope that was fueled by groundbreaking research, extraordinary doctors, and the unwavering support of community, many of whom are here today, including my family and friends, and even my oncologist, Dr. Ruta Rao, who in a true full circle moment, she is in a true full circle moment also the lead of the Chicago Breast Cancer Research Consortium you're going to hear about today. So I think there was some kismet in the universe. My own diagnosis drives my commitment to ensuring that discoveries are faster from the lab to the patient, so that every person facing breast cancer has access to the same hope that saved me. Lynn Sage Breast Cancer Foundation has been a leader in Chicago advancing breast cancer research since 1985. Over nearly 40 years, we've raised more than $50 million. $50 million to fund bold science and life-saving care in support of our mission, to eradicate breast cancer by investing in early career doctors and innovative research. Our portfolio includes research grants that spark groundbreaking new ideas, fellowships to train the next generation of breast cancer specialists, and in partnership with Northwestern and World Business Chicago's Sister Cities program, Travel Awards, that bring doctors from across the globe to the renowned Lynn Sage Breast Cancer Symposium. None of this would be possible without our dedicated board of directors, the daughters of Lynn, Hallie and Laura, who carry forward their mother's legacy, the incredible Lynn Sage team who works tirelessly to bring our mission to life, and our generous donors who make progress possible. Today, I am especially proud to share with you our newest initiative, the Chicago Breast Cancer Research Consortium. Convened by Lynn Sage in 2024, it brings together 3 powerhouse institutions: University of Chicago Medicine, Robert H. Lurie Comprehensive Cancer Center at Northwestern Medicine, and Rush MD Anderson Cancer Center, for a first-of-its-kind national model for collaboration to expand breast cancer clinical trials. For the first time, a trial developed at one institution can now be offered seamlessly across all 3, expanding access, accelerating enrollment, and strengthening science. This also means that patients can stay with the doctors they trust close to home. Barriers like childcare and transportation are reduced through a dedicated patient support fund. Top researchers from across the region have a space to collaborate and develop an infrastructure for data sharing. And trials have more diverse participation, which strengthens the science itself. Through the consortium, hospitals are working together, accelerating research, advancing equitable access, and bringing better treatments to patients faster. The Chicago Breast Cancer Research Consortium is more than a partnership. It is a proof point of how collaboration accelerates discovery and equity in cancer care. It also reflects something I've seen throughout my career. When we collaborate, we create solutions that truly transform lives. To our hospital partners, thank you for your leadership and steadfast commitment to our patients. This collaboration is only possible because of your vision, and we are honored to be in this fight with you. As I ask you to join me on stage, I also want to thank our extraordinary panelists, leaders whose accomplishments have helped shape the field of oncology. Dr. Ahmed, Dr. Odunsi, and Dr. Platanius, your leadership within your institutions and your commitment to collaboration set the standard for what scientific progress should look like. This work is stronger because of your example. And with that, I am honored to join our panelists and dive right in. Okay, good seamless mic transition. Thank you again for joining us today. We would love to start with introductions, as well as what makes the consortium such a unique and transformative model for clinical research. And we can just go right down the line.
Hi, everybody. I wanted to thank you for inviting us. My name is Amina Ahmed. I'm the director of Rush MD Anderson Cancer Center. I'm a GYN oncologist, and my interests really lay more in geriatric oncology, specifically treatment of older adults with ovarian cancer. The consortium, just as Kirsten said quite beautifully, really breaks down, I think, the barriers across excellent institutions where all of the, the researchers in the disease space of breast cancer can collaborate seamlessly and bring novel trials to our patients without any issues across institutions. This also provides opportunities for our young investigators who honestly bring the most innovative ideas. I can't say that as we're getting older, we become more innovative. That's actually not true, but our young faculty are the most innovative. And so I want to congratulate all of you on this consortium. So thank you very much.
Thank you, Dr. Ahmed.
Hi, I'm Leon Platanius. I'm the director of the Lurie Cancer Center of Northwestern. I'm myself a medical oncologist and researcher. And I have to say that when I first heard about the consortium, I thought that this was a superb idea. It is the first time that a foundation really transforms the delivery of clinical trials and care in a big city like Chicago. And this is so important, for cancer patients. That's what I like to say all the time. Clinical trials equal clinical care. The time they are on a clinical trial, that's the care they get. And this may well end up being better than the regular care if the trials work. So to coordinate this effort in a big city like Chicago is a big deal and creates a new standard, something that will be important for years to come. And maybe it will become more broad. It will become a national standard. Maybe it will involve other centers across the country. But this is an important first step that will make a big difference.
Yeah, I also want to thank the Lynn Sage Foundation. My name is Kunle Odunsi. I'm the director of the University of Chicago Medicine Comprehensive Cancer Center. My clinical discipline is gynecologic oncology as well. I deal with patients with cancers of the female reproductive tract. My research is focused on asking questions about how the immune system recognizes and destroys tumors, leading to the establishment, part of our work, leading to the establishment of immunotherapy as a major pillar for cancer treatment. I am so excited about this collaboration. I think it's unique, it's innovative, it's transformative for several reasons. Clinical trials, let me add on to what Dr. Platanius just mentioned about clinical trials. Clinical trials really are the engine room for discovery and for cure. In the olden days, back in the days, when you put a patient on a clinical trial, it's like there are no options left. That is no longer the case. At the present time, even with phase 1 clinical trial, these trials are designed with the intent of cure. It's not because there are no options left. In fact, many times, patients who are perfectly healthy, even during their first-line therapies, are put on clinical trials because those trials are based on very strong, new emerging scientific evidence. So I am so excited about this collaboration. It has important implications for our patients, allows patients from all parts of Chicagoland to have access to innovative trials from these 3 eminent institutions.
Well, as you can hear, our experts are incredibly knowledgeable and really advancing the field. And so that's one of the reasons that the consortium focuses on investigator or expert-led initiated trials. Dr. Platanius, can you talk a little bit about why this is significant and how it allows for more bold and responsive science?
Yeah, it's in many ways bringing together 3 major institutions with a specific goal is a big step. And it incentivizes the doctors to work together to become really one team. It also allows diversification of the clinical trials in larger groups, different parts of the city that are covered by different institutions. And this is very important for many reasons. By the way, in the city of Chicago, we have what we call cancer disparities. And in certain parts of Chicago, the outcomes of women with breast cancer is much worse than in other parts. And by broadening the network of clinical trials, trying to bring it across the board, that's another thing, another benefit that will hopefully come out of that. And I think also, cancer is a complicated disease. It's a very complicated problem. And having, a more diverse group of scientists and doctors that work together to develop clinical trials allow for exchange of more ideas, new ideas that otherwise wouldn't be there that could make the difference. So for all these reasons and more, actually. So.
Thank you. And to build on that a little bit further, what Dr. Platanius noted is because of the catchment areas of these 3 hospitals, the consortium has essentially coverage across the city of Chicago, and this helps to make a more diverse patient population possible. Dr. Odunsi, can you speak a little bit more as to why this diversity matters, specifically in the development of effective and patient-specific treatments?
Yeah, diversity matters quite a lot. First of all, in terms of just a question of access, University of Chicago Comprehensive Cancer Center is located in Hyde Park. You have our catchment area includes the south side of Chicago, for example. What we have found is that the risk of cancer or death from cancer is much higher in our immediate catchment population compared with other populations. And then if you look at enrollment in clinical trials, again, remember, clinical trials potentially could provide cure, could potentially allow us to understand new aspects of biology of disease. And yet, if you look at enrollment in clinical trials, there are certain populations that are underrepresented in clinical trials. I'll give you an example. Multiple myeloma, for example, I know it's not breast cancer, affects African American populations much more than other populations. But if you look at the clinical trials that led to approval of some drugs, I think only about 2 or 3% of the clinical trial population were represented where there were African Americans. And then no wonder sometimes the drugs do not work as effectively in some populations compared with others. So that's just an example. So I think it's important to have diversity, and this collaboration, this consortium, allows us to touch every population in Chicago, allows us to share data, compare notes across Chicago, which I think in the long run will be of better benefit for our patients.
Absolutely. And we've heard the excitement in all of your responses, and it's inspiring to think about and exciting to think about what the long-term impact could be of the work of the consortium. So, Dr. Ahmed, what do you hope to see in the next 3 to 5 years, both for patients and, as Dr. Odunsi alluded to, the broader research ecosystem?
So I think, so again, like I said, congratulations on the consortium. I think the footprint of the consortium will really allow other disease entities to follow suit. That's really my hope in the next 3 to 5 years. And so we already, Chicago is a small, big city, right? And so we already collaborate with our colleagues across all various disease entities. And so we do it formally, informally. We have second opinions. We have, if there's a trial open at University of Chicago, I'm sending my patient there if I don't have it at Rush. And so having this consortium, but then I lose my patient, like you said, right? And for like a temporary amount of time. Having a consortium in the breast cancer space is novel for Chicago, period. And having that same platform for all of the other disease entities to follow as a blueprint, that's what I'm really excited for. The other piece I really want to make mention of is that funding, government funding right now is really uncertain. And so we will heavily rely on philanthropy, foundations to push the trials forward for our patients. We can't push cancer research forward without that help. And so in the next 3 to 5 years, we really will see the effects of what's happening from the last year or so. So those are the areas. I'm excited. I'm, again, very grateful for what you guys have put forward. So thank you very much. Yeah.
Thank you. Please, Dr.
Yeah, I just want to add, I see it like this, but also a little different. Because this effort is in breast cancer, which is the most common cancer, very treatable at some stages, but then very fatal for people who don't respond. My hope will be that this will grow and expand in other cities. It could be the beginning of a national effort. There are other cities in the country with high disparities, with similar problems with Chicago.
Right.
And if this effort is successful in Chicago, it will create a new model that could be adapted in other cities, either by Lynn Sage Foundation, I hope, but also other foundations may look at this and say, oh, look at that, that works well,
To that point, you basically are consolidating efforts, right? I mean, instead of having small pockets of efforts, you're making one large effort. So, yeah.
And the other point is there's going to be a multiplier effect where, as a result of what we are doing in this consortium, it leads to ability to generate new questions and potentially obtain even more funding to be able to test those questions and improve the outcome for patients.
Absolutely. Well, we heard from Dan, we have many survivors in the room, and whether or not it's breast cancer, we know, unfortunately, that so many of us have been touched by cancer. We've talked about how the consortium helps to advance research and treatments, but as I know firsthand, survivorship is also such a critical part of the journey. Could each of you share a little bit more how the consortium's work may impact survivorship more broadly, and why investing in survivorship matters both to your institutions but to the field as a whole?
I can start, yeah. I mean, I think with your consortium, right, I mean, different investigator-initiated trials may address different survivor or thriver issues, actually. We like to now say thrivers, right? And so they would put forward different trials to be opened at the institutions in the consortium. And so I always like to say this, and I know the Rush table may have heard this already. We really do invest a lot in primary oncology, but we want to equally invest in the supportive realm in oncology because our patients, thankfully, are living longer and we want them to live better. And so we really do invest in various different programs to support our thrivers.
So, you know, the definition of survivorship is something that we have to be clear. Every person who has cancer at whatever stage of their disease is a survivor. And then there are the long-term survivors, people who have been cured from the disease. So this effort will have a tremendous impact on survivorship by enhancing our efforts to have more survivors, but also because it will be a wider network of trials with larger populations, providing another way, another approach to look at the effects of treatments on survivorship, short-term, long-term. So there are many benefits across the board that we will see. And also prevention, but we can get on that later.
So I think survivorship is so critical, and I agree with Leon's definition. In fact, I think that's the definition that both the American Cancer Society and the National Cancer Institute have adopted. The point is, with survivors, it's important not to just think that at the end of treatment we leave a patient alone. So from the point of treatment, how are we supporting not just the physical well-being, but also the mental, emotional well-being during treatment and after treatment? So some patients will be categorized as long-term survivors, some are shorter term. What kind of clinical trials can we design to help long-term survivors, short-term survivors, essentially across the spectrum? So I am hoping that with this consortium, we'll be able to cover the entire spectrum of helping survivors, whatever the stage is.
Thank you. We've talked about new frontiers in cancer research, but I'm also curious to hear a little bit more about innovation in cancer care, which I think we were touching on a little bit with survivorship. So, you know, for example, we know that cancer care has been revolutionized in recent years by genetic testing that can lead to really more personalized treatments. What breakthroughs or technologies give each of you hope?
I feel kind of like I'm cheating because I'm first the whole time. So
We can force Dr. Adunsey to go first.
Yeah, and then I'll go this way. Yeah, that's probably better.
So there's so many things going on in the field right now. One that I'm very excited about, actually there are many that I'm excited about in terms of breakthroughs in care, really is the use of artificial intelligence. So AI, whether we like it or not, is helping. I mean, there are very good uses of AI. So you can sit in a consult room, see a patient. I'm sure when you go to your doctor, you see your doctor typing away and trying to create notes. Even without touching your computer, AI is able to summarize that visit for you completely. And that is helping the doctor to pay more attention instead of focusing on trying to catch up and do their notes. Moreover, AI is also helping to identify the best possible therapies for a patient. If you look at the medical literature, if I was to put in breast cancer and Google search, millions of publications, millions of data available out there. There's no way a single person can keep up with all that information. AI is helping us to process the information, even to the extent that now we're developing AI co-scientists to help us think about new hypotheses, new questions that can be tested in our patient populations.
So Okay, let me get into the AI also, because I guess we are. So first of all, I think AI will be very important for diagnostic purposes. In fact, if I remember correctly, there was a study from Northwestern a few years ago that showed that AI can read better mammograms, and I'm saying that with the risk of alienating some people here. Have to be careful, but than doctors, which again, so clearly AI is a way that will enhance at least the diagnostic capabilities that we have. But if you see it, maybe we disagree slightly here. I think AI is extremely important to summarize what exists. AI, all this data that Kunle mentions, can analyze them quickly, and within a few minutes, you can have a summary of what's going on. I still believe, though, that research innovation, the major breakthroughs that will change medicine, will still rely on the human factor. I don't think AI will be able to do that. It will be a huge...
Yeah, I agree with that.
It will be a huge help, but it will require the human factor, and we can talk more.
I agree with this. I mean, I'm going to weigh in on the AI too, sorry. It's like, AI in medicine is front and center for us, right? I mean, we have various different biotechs, et cetera, coming to us about AIs and how to use it. But quite honestly, I agree with both. So that's why it's nice that I'm last. So I think that when we started moving down the road of precision medicine, everything that we do when we treat patients with cancer is biomarker driven. But that opens up a large box of data for our physicians to go through. And so the usage of AI, in my mind, is similar to what Dr. Adansi just said earlier, was to really provide summaries. So there are tools that AI can provide for our physicians to then actually make their work much more seamless. There are also tools in AI that we'd like to utilize to identify patients who could be clinical trial eligible, who we may be missing something in the arena that we can then look at. So there are multiple usage. But I would never say, and I'll say that clearly, it does not replace, the clinician, the expert that is trained to take care of a patient. And so, yeah, I mean, I'll weigh in on the AI. I think the AI is a nice topic. But I'm excited about AI. I think also probably I would like to maybe we could talk about cell therapy, if you want, if you don't want. But I'm excited about different kind of cell therapies. I mean, these two though I would tell you that cell therapy is an avenue where we are utilizing patients, either their tissue or their blood, to transform those cells to then treat their cancer. It's standard in hematologic malignancies, but it's becoming more and more prevalent in the solid tumors. And so I'm excited about that as well.
I can move on, or we can talk more about cell therapy. I
just threw it out there, but I think it's very exciting. So yeah.
Cell therapy is really very exciting, and one of the major areas of use of cell therapies is really to take a patient's own blood, take the immune cells, re-engineer the immune cells, and give it back to patients. So you grow those cells to billions and billions, and you give it back to patients. So cell therapies have revolutionized the treatment of certain blood cancers, but not so much for liquid cancers. So some of the coming breakthroughs is actually in the area of cellular engineering. We are now able to program those cells, instruct the cells, the immune cells, to tell them when you see the tumor, switch on, go on the attack or not attack. You can program the cells to commit suicide if there's too much side effect. You can program the cells to do multiple things, to carry a load, like a cargo, and deliver it to the tumor. So those breakthroughs are going on as we speak in terms of novel, innovative approaches to engineer immune cells. And these are beginning to get to the clinic, and hopefully will be useful for many solid tumors, including breast cancers.
So let me just add, what Kunle just said, cellular therapy so far work for leukemias, lymphomas, for liquid tumors, not solid tumors. Interestingly, AI has not figured out why. We still don't know why. But I think the major breakthroughs are coming in multiple other ways. We have a program at Northwestern, the Translational Engineering Program, where we have engineers designing antibodies with multiple arms. Instead of regular antibodies that have 2 arms and they can interact with 2 cells, we put 5, 6. We create monster antibodies to attack cancer and bring many cells together. So all these things, and there are so many other efforts like Kunle mentioned, that they will take time, but they have the potential to be transformative using the immune system. And that's the key. The immune system is extremely powerful. And so far, we have found some limited ways to use it with the checkpoint inhibitors, the current cellular therapies. So we have a minority of patients who get cured or who take advantage. Most of the cancer patients still do not. Mm-hmm. And that's the future. We will change that in other ways, and hopefully everybody will get the benefit.
Well, that is a great segue. At Lynn Sage, we believe that breast cancer can and will be eradicated through these intentional investments in research. I want to thank our panelists and partners for sharing how we are moving this vision forward. And as we transition, I will ask a pre-submitted question, but please join me in thanking them for all of their time and expertise. So I'll turn it over to Dan, but we have a pre-submitted question, and this kind of dovetails nicely on the cell therapies and AI. So, as we think about the new frontiers in cancer research, how might the unique strengths of the consortium and your cancer centers as a whole help to move the work forward?
So there are several unique strengths in each of the institutions represented here. At UChicago, for example, let me go back to AI. We have a very strong AI program that is allowing us to discover new drugs very rapidly. This is perhaps one of the best programs that I have seen, where you can, within minutes, interrogate the entire chemical space and ask what chemical compounds can be useful for this particular cancer type using AI. Billions and billions of compounds very rapidly. And so, of course, you still need a human in the loop. You need somebody to take a look at the data. But this is allowing us to very rapidly move forward. This is a collaboration with the Argonne National Lab, which is operated by the University of Chicago. We have something called the Aurora supercomputer. It's the fastest computer in the world right now. And we can process 1 billion times 1 billion events per second. So it is, I can't even pronounce it. I think it's quintillion or something like that.
If you can't pronounce it, we will, so it's okay.
So drug development, and hopefully some of these drugs will get into the consortium.
So I think it will, and it should have impact on cancer prevention. There are right now, as Kunle said, many ways to do very rapid screens, get many drugs that you can quickly bring to the clinic. And to me, the biggest achievement will be if we can stop cancer before it appears. And right now, we have some preventive ways. We do mammograms, we do other things. But there could be a way that if you know you are at high risk, there will be a pill that you will give to someone, and that will be it. We can get to that level. So I think it will be very important for this consortium to keep an eye on cancer prevention trials, because that could have a much higher impact than just treating advanced cancer. Of course, they are both very important.
I think in line with that, Rush has great population health research. We really do go into our communities on the west side. And so I think that's really where we can have value added, part of it with prevention, and then obviously community outreach. And so different types of initiatives within the consortium is really where I think our strength lies from the Rush cancer side.
It just helped answer another pre-submitted question, so gives us time. We've got a few minutes, and I would love to get any members of the audience who have a question, please raise your hand. I'll come out to you, and if not, we'll get to our written questions. So does anyone here have a question? Great, I'd love to ask you to introduce yourself and what organization you're with, if you could.
Dr. Rao and Dr. Madrigano on my team at Rush. I saw them look at each other like, yep, Paula's going to have a question. When you look at the clinical trial landscape, what Kristen was saying of there are more and more survivors due to the work of scientists, when you look at the clinical trial landscape, it seems like a lot as if you have an active malignancy. Do you see that there's going to be more dedicated to survivors, particularly breast cancer, for either prevention of recurrence or surveillance through ctDNA, et cetera?
Yes. There are different investigator-initiated trials and different types of cooperative group trials that are tailored to not just active disease. So, and that's true of all disease entities. So yes, to answer your question.
Yeah, no, I agree.
Okay, yeah.
I think that's clearly something that will happen. Nothing to add to that.
Okay, I'm going to ask the clerk to introduce herself.
Hi, Anna Valencia, City Clerk. My question had to do with federal funding. How, as we look at the landscape now with cuts to research and medical funding, is this consortium the way of the future to also make sure that we have forward progress on research? Love to hear your thoughts on that, and how does this funding, especially the work of the foundation, more important now than ever?
I think the short answer is yes, the work of this foundation is more important than ever. Federal funding is unpredictable at the present time. In fact, if you look at grant submission to the NIH, to the National Cancer Institute, the major grant that many of us utilize for our research is called R01 grants. R01 grants right now are going to be funded at the 4th percentile, meaning for every 100 grant proposals, great ideas submitted from UChicago, Northwestern Rush, these big ideas, only 4 out of 100 will be funded. 96 of them will be turned down. That's the current reality, so the work of the Lynn Sage Foundation becomes even more critical. And during this time, we have to continue to focus on our excellence, continue to focus on building this consortium so that we are prepared to be stronger, hopefully when funding returns.
And I would add, also maintain our researchers, right? Because their current funding and their current work is also at risk. So we're not just talking about new novel treatments, obviously those innovative ideas that we need to have to treat our patients with cancer and preventative and our thrivers, survivors, but also maintain the current researchers.
If I may add, this 4% is a dramatic drop, because it used to be 10% before, and years ago up to 20%. So this is something, though, that I'm hopeful that at some point will be reversed, because cancer is a bipartisan issue. I don't think there is anybody on either party that doesn't want to fight cancer. So it's a matter of advocacy, information. People don't know that, and that's why I think it is important for as many people to make that clear. On the other hand, what this consortium does is, brings new clinical trials. clinical trials do not get traditionally funded to a large degree by federal funds anyway. So I think that these are two different things. Foundations will have a much bigger role in what they do these days. Hopefully this decrease in federal funding will be reversed. But the clinical trials, I think we should see them as a separate effort with its own goals. And of course, all that matters for cancer research.
All right, we have time for one more if anyone has one here. And if not, there you go, Terry.
Good afternoon. I'm Tariq, but I'm a family physician from Access Community Health Network. It's the largest federally qualified health network. Guest of Chicago Sister Cities, you bring all those 29 physicians from across the globe, you know. So my question is, I mean, first of all, it's a great discussion about prevention and, of course, treatment. But, you know, like, I really serve all those zip codes where we don't have the luxury of having University of Chicago or Rush or Northwestern. But I'm very happy that these hospitals are available to us, you know, for certain patients. But, you know, how can we help hospitals like St. Anthony's of the world? I belong to Mount Sinai Hospital myself, but we cannot send all patients to Mount Sinai. And you guys are our only hope, like Moses in the ocean, you know, like try to find, you know, to figure out a way to get every patient connected to you. How can we strengthen those hospitals, you know, which are like Roselands of the South Side, and they are in close proximity with University of Chicago, or all federally qualified healthcare networks, despite the fact we do have inroads. But how should we figure out a way to formulate a regional delivery of care health model which can serve across all zip codes and give equal advantage to all patients? You have to really figure out a way.
It's a difficult, years-long question. But I would have to say I'm going to say this to my colleagues, and it's similar at Rush. You know, all of these university health systems traverse and cover all various communities as well. So our systems for health are also in the community. Our physicians go out to the community. We have open clinical trials that are overseen not just downtown, but come out to the community as well. And so to your point, we talk about health equity, but the equity has to also not just be, we have health disparities in the city, and we have disparities in the community, because we see that. We see referrals from the community, and I'm like, you're like not very far away from Chicago, but you're getting substandard care, right? We see that. But to your point, we make real efforts to make sure that the care goes to the communities as well.
So the only thing I want to add is that all these systems, all these universities have healthcare systems that have other sites beyond the main site. For instance, at Northwestern, we have 11 hospitals, a total of 14 cancer-serving sites, and we open our trials across the network, so essentially patients don't have to drive downtown. And I think, I'm assuming the same will be for everyone else. So for patients in other places, Mount Sinai may not be part of these groups. I think they're separate. But, you know, at some point, if it is in the interest of the patient, you may refer them to one of these sites transiently to be on the trial and then come back. So I think just having large health networks that will support this consortium will make that more possible, bringing it all over.
Yeah, so let me just add that this is work that we should do. It is work in progress. So for example, at University of Chicago, we have all these network sites, but we need to partner with you, the federally qualified health centers, safety net hospitals, to make sure that those patients are getting appropriate care. We need to have navigators in the community to help navigate them. We need to have programs of outreach to make sure that we're engaging with you to navigate patients properly. So in fact, all of our institutions have this community outreach and engagement program which allows us to engage with partners like yourself. It is not perfect, but I think it's something we should keep our eyes on.
Thank you. Thank you for all of that. Thank you for your questions and, of course, for being here. As you mentioned, Doctor, it's a work in progress, but we look forward to welcoming you back to share all your success, right? Which we hope will be sooner than later. So please come back, share that great success. We hope you all will come back. As I said, we have a very busy September on the 8th. I think that's just a couple of days. We have How We Heal, Building Connection and Solidarity in Divided Times with the Kellogg Foundation and the Joyce Foundation. We've got the current state of immigration. There's a lot happening right now. Facts, Impacts, and Realities on September 9th. Inside the Chicago Architecture Biennial on September 11th. Closing the Housing Gap on September 22nd. Cook County Sheriff Tom Dart on September 23rd. Commissioner of the Water Department on September 30th, Advance Illinois in Education on, I don't have the date, check our website. Ambassador Rahm Emanuel in October. There, you see, we're tackling so many different issues and have so many incredible speakers. The brain power in the room today, I think, might exceed a lot of these, so thank you so much. And we have a raffle. Come on up. Thank you, Emily. See, you're definitely going to want to come back if we give things away. I'm going to ask Corey to pull the name.
No pressure.
No pressure. Okay. David Kuriakis, am I right there? I have your cell number too.
It seems a little suspicious. You're sitting right next to the drawer.
Oh, wait a second. You've got some Lindsay swag on the way out. Thank you. Thank you all for all of your support. Thank you, doctors. Thank you, Kirsten. What an incredible panel. And please check our website. Come back often, and maybe go back and if you missed anything today, you can watch the video of this and all of our other programs, and I'll just soak in some of this incredible knowledge. It's great having you all at City Club. We welcome you all back soon. Have a great week and great September.